Good morning, everyone. Thank you for joining. So today we have Kendra Knudsen here with us. She is one of our psychology interns in the general child track. She also hails from the UCLA Clinical Psychology doctoral program within the Torpedo Lab. She has a clinical specializations in trauma-informed care, adoption-sensitive therapy, and cognitive behavioral therapy for all ages. She's also certified in managing and adapting practice and beat the odds, and brings additional expertise in treatment engagement and social emotional skill building through expressive arts. As founding director of the Creative Minds Project, a program of the Arts and Healing Initiative, Kendra is passionate about implementing mental health protocols in the community. And having previously coordinated research on everyday and exceptional creativity within the Builder Lab at UCLA, Kendra's research interests include designing and integrating innovative client and provider-facing interfaces in clinical care to enhance clinical decision-making and treatment. And I neglected to mention, I'm Emily Ricketts. I'm an assistant clinical professor here and the associate director of the clinical psychology internship and director of psychology practicum training. Kendra will be presenting on clinical decision-making with structured supports. And her presentation is going to be about 45 minutes long today. So that's going to leave time for questions at the end. Feel free to submit your questions during the presentation, and I will get back to them at the end. And if we do happen to wrap early, then we will end a few minutes early. All right, well, thank you. And now I will give the floor to Kendra.
Thank you. All right, so I'm gonna share my screen. Okay. And I think you all can see just the slideshow. So I have no disclosures. So there are three key barriers for accessing mental health services. One is content. So many psychological treatments are complex packages with multiple variants for each single mental disorder. Many are proprietary, and people believe that they require extensive learning and supervision to deliver. Another piece is supply. There is a massive shortage and inequitable distribution of certified mental health providers. For example, in India, there are about 0.6 mental health workers per 100,000 people. And compared to this with the numbers for high-income countries like the US, around 50 per 100,000. Another piece is scalability. So when designing treatments, we need to serve a large portion of the population with a diversity of mental health problems. And when designing these scalable solutions, we must balance often competing treatment needs. So in the service of reach, treatments are often simplified to increase accessibility and reduce cost, which might include removing or standardizing procedures. Yet this also decreases their utility and applicability across broad contexts. And so we must strike this balance for treatments and decision-making processes to be uncomplicated for mental health workers and to support the delivery of treatments that are widely suitable for diverse cases. And so then that will help us achieve effectiveness as part of the scalability equation, having functionally meaningful change. And to increase the effectiveness of our treatments, we must manage knowledge, including what we have from the research literature, evidence from cases. And we may consider that case conceptualization process with treatment planning as following the general cycle of what is the problem and what should we do about it. And this can be seen as our general plan, do, study, act cycle from Deming. And Graham and colleagues have created a conceptual framework for knowledge management, which I present here, which includes considering a problem, such as referencing multiple sources of evidence, identifying a problem where you compare scores on various measures with expected values to later select the problem, so prioritizing the main problem over other possible ones, and then doing the same kind of approach with considering and selecting a practice. And then after implementing a practice, measuring how well that practice did, either how many steps you did in delivering that practice or how the patient responded, and comparing that to what you expected to see, and then continuing that cycle over again. So here is an example where one might be considering, does this patient have anxiety, depression, or trauma, PTSD, for example? And then you might identify a problem by gathering information from various measures, selecting anxiety as a focus, perhaps because it's shows the greatest severity in this patient, and then considering a practice such as, do I move to psychoeducation about anxiety, teach the patient coping skills, establish a fear hierarchy, and then selecting that one practice to focus on in the next session, and then measuring how well you implemented that practice, how well the patient responded, and continuing throughout that treatment process. So clinical supervision commonly focuses on this goal-oriented planning and implementation process, and it is considered the gold standard for building mental health providers' productive capacity and to also improve clinical outcomes in patients. And the supervisory team faces many challenges to deliver high quality care. They must race to incorporate findings from a massive evolving a body of science and evidence that guides their competency targets. They need to sufficiently master several competencies to maximize coverage of a service population. They have varying baseline levels of competencies, which develop at different rates. And then due to workforce turnover, they must perform up within a limited amount of time. So we see all of this occurring within the treatment. And this clinical work is complex, and without having structure to guide decision making, people can take shortcuts and are often unaware of these shortcuts or biases. So they might use incomplete or faulty information to identify problems in treatment. They might select from just a few known practices that might not be well suited for that patient. And they also might implement those practices without much clinical guidance, and they might not evaluate the impact of those practices used. And so structured decision-making supports can help with these challenges by increasing the organizational quality of the decision-making process, and also decreasing the time or effort needed in making those decisions and delivering quality care. And it does so by managing knowledge through strategies such as filtering, aggregating, and layering. So filtering enables the user to sift through large volumes of data, identify and extract out the most relevant information particular to a decision-making point, and focus on key insights. And then through aggregation, you can consolidate different sources of information, such as through the research literature or case-specific measures, and present it in a cohesive and structured format. And then by layering information, you can explore different levels of details. And with increasing proficiencies, users can navigate from more general to more detailed layers as they, become more, create this appetite for complexity as they continue on in their learning process. So the first study I'm going to talk about I was asking the question, can decision support systems train providers in India to select case-specific intervention procedures? So this was a study I conducted in the context of my work in the Torpedo Lab at UCLA, and in collaboration with a team at Harvard and Sangath in India, in which these teams developed this PRIDE protocol to be delivered for adolescents in India, facing anxiety, depression, and difficulties with anger. So the plan was to build the treatment protocol directly in context to address the issue of content that I described earlier. So combining local and research knowledge attuned to the potential uniquenesses of India. And also to address issues of supply and scalability, the team enlisted non-specialist mental health workers to deliver the protocol. And then our team emphasized flexible, multi-problem, modular treatments in order to effectively treat the diversity of clinical presentations that we saw in this population. So here's an example of just a treatment plan where we had the 3 possible problems and then practices used to address those problems. And the providers would go up that tree. And at this phase 2 is where the providers were faced with the decision of which module to proceed with, which problem do they want to focus on, anger, anxiety, or depression, which then helped guide them in picking which practice to use first. And here's an example of a decision-making support to help guide their delivery of that treatment, where you see different steps. And 1, 2, 3 on the side there shows, the first time you deliver this practice. If you have very limited time, you just do this one piece of the step. But if you have a lot, more time, then you might deliver more. So they were happy with that decision-making support that I showed you earlier, but where their concerns was that step 2. How do I choose where to go next? How do I know which problem to focus on and thus which practice to deliver? And they thought that protocol, making that decision on their own, was too complex. And the providers said, I can't do this. And what sparked this study was that this concern that they said, I can't do this. And we said, well, let's find out. We believe you can, but we truly don't know until we test it. And so let's do a study. And so my questions were, can we increase these providers' ability to select problems and practices, focusing on this piece of that decision-making process? Can we also increase their confidence? And can we make this decision-making process usable and acceptable? And so in terms of the procedure, we developed different clinical vignettes, piloted them across multiple providers of our team, which included folks from UCLA and India. We tested out these vignettes with a group of highly trained judges with expertise in modular treatment designs. And we established this criterion of what would be, acceptable treatment plans based on these vignettes. And then we delivered a 2-hour training to our study participants and gave them a decision-making resource, which I'll show you next. And then before and after the training, the participants answered questions on which problem and practices they would select, and then their performance were compared to the criterion established by the judges. And so here are our participants. They were all mental health workers in India. It was a pilot study with 18 people, all female, around 30 years old, at least proficient in English, most fluent in Hindi. They had a diversity of training experiences and a wide range in years of experience delivering mental health services. And so for our outcome measures, I looked at task performance, so their ability to select a problem across 4 case vignettes. So they got a summary score for that. And then similarly to select a practice. So again, a sum score across each of the vignettes. And we also measured their self-confidence on a Likert scale and their actual experience based on the UTAUT, which is this established user-centered design survey that asks about, did this resource benefit your performance? How easy was it to use? Do you think it's valuable? Is it valuable to people who are important to you? How much you enjoyed? Do you plan on using it? And do you think you'll use it regularly? And so I'm going to show you a vignette that we used, and we can look at it together and see what it was like for them to go through the training and then also to consider the problems and practices here. So here are the questions that will be asked of you as you do this with me. And here's the vignette for Jyoti. So you see that you have youth top problems, strengths and difficulties questionnaire, and also some clinical benchmarks to consider. And so you can see here in the case notes, there's some description on Jyoti's behavior. We can see how long that she has had these symptoms, her age, and what the provider is observing in session. So this was presented in like a training where Dr. Torpeda presented the training in India, and the providers were needing to grapple with this issue of comorbidity, where there are some symptoms that clearly align with these treatment targets, and then other ones overlap across. So some are not unique and they can have shared solutions. And the challenge that the providers are facing, that most problems co-occur, so there won't be a right answer, and the provider's job is to find the best answer or one of the best when making their decisions. And so here's our decision-making resource that I developed with Dr. Torpeda. It went through this CARE process. So considering what the possible targets are for treatment, answering. And so as you can see, there's just a bunch of symptoms over here that map onto these various problems. And then they're supposed to answer whether the youth has a mental health symptom, and then they respond. You can see that the boxes, that some of them symptoms overlap based on the problems. And then they evaluate by finding the scales to test their treatment. And this resource strategically assembles this process in coordinated action steps that mirror this plan, do, act decision-making process. And so their job is to identify the most likely problem and the most effective practice to resolve that problem. And then here's that vignette while using that decision-making worksheet. So as we read this vignette, we find various symptoms, and then we check off in the answer column where those symptoms occur. And then looking to the right here, those symptoms correspond to the various treatments. And you add up how many symptoms there are, and there were more symptoms that aligned with the treatment for anger, so assertiveness training, and so that was the selected treatment. And then the evaluate would be perhaps using youth top problem and looking at the level of irritability to see the patient's response. And so the providers went through these 4 vignettes, answered these questions, used that decision-making worksheet to guide their responses. And so gathered all that data and conducted analyses on these 3 research questions. So for the first question, I used multiple regression model with ML estimation because there were some missing values, and looked at multiple regression model to look at that Likert scale on confidence, and then descriptive statistics to understand their user experience. And so here are the results. So I realized that the colors aren't great. So the pre-test are on the left and post-test are on the right. And you have decision-making surrounding identifying the problem and then identifying the practice. So before the training, the providers performed below chance on 4 vignettes. And they weren't able to match like the criterion from the judges on any of the top 2 of the 3 possible problem selections that the judges identified. And then in terms of the practice, they also were performing at around chance. And after the training, as you can see, they were able to select 3.67 out of the 4 vignettes where they were selecting treatment plans that the judges would agree with. And overall, approximately 25% more cases matched the judge criterion on practice selections, and approximately half of 46% more cases matched the judge criterion on problem selections. And their confidence increased from pre-test to post-test, almost 1 unit. And then their experience was quite high utility and acceptability of that decision-making resource. The vast majority reported somewhat to strong agreement on nearly all these items, looking at usefulness, enjoyment, usability, and whether or not they would plan to use this again. And so they reported confidence in their reported confidence revealed that they found the process empowering, and their increased accuracy in making these problem and practice selections demonstrated that this confidence was an honest signal. And so the conclusion of this study was that by using decision support systems, by integrating evidence into this care process, we can greatly improve the ability to harness evidence and make better decisions. And by exposing a decision-making algorithm to people, simply adding up symptoms and seeing, where they correspond to treatment targets, that helps people have a visual way of breaking it down and being able to demystify this complex decision-making process. And it's also showed the value of attesting assumptions about the capacity of a mental health system rather than just kind of going with this I can't do it kind of mentality, like using evidence to guide decisions, even in the design of systems and treatment processes. And highlights the importance of not constraining solutions to simplification, which is often a strategy when working in low to middle income countries. So rather than simplifying the decision-making process, we provided a decision-making resource so they could make these complex decisions and have more confidence and be more accurate in their work. And the limitations, this is this very small sample size pilot study. We didn't have a control group. It was a within study pre-post design. And the participants were more experienced than the mental health workers that we eventually would want to be using these resources to help, increase that scalability. So the second study is on work done in the US specifically. And the question I asked was, can decision support systems alter the process of clinical supervision? So this study I conducted in the context of the Torpedo Labs work in this Reaching Families decision support system, particularly in the domain of targeting treatment engagement. So engagement is an individual's ongoing and meaningful involvement in services. And we can understand it across multiple dimensions. So for instance, therapeutic alliance, so the relationship that the patient has with their therapist, expectancy. Does the patient think that the treatment can help them get better and improve their life? Attendance, is the patient coming to therapy? Clarity, are they clear on what the treatment goals are and how they will meet those goals and what the process will be of treatment and the practices that they'll be doing? And homework, are they practicing their skills outside of the session? And are they practicing and participating in the session? And across these 5 reach engagement domains, there are several engagement practices one can use that can target various problems. So accessibility promotion, for example, can target attendance. Facilitating skills mastery can target participation and relationship and so on. And so here are some just examples of an engagement practice and its objective. So we often use psychoeducation about services that can help with relationship as well, expectancy. So some of these target multiple problems, and other ones like appointment reminders might target just one, where it's really focused on attendance. So here is the decision support system. So the first piece of the system it focuses on identifying problems. So there's a My Thoughts About Therapy survey that youth and families were to complete, which measures these 5 different reach domains and provides a score on their level on each of those domains. And if you'd like to use it in your own work, you can go to Dr. Torpedo's website and download it, and there's measures and user guide and everything. And in terms of the practices, the participants in this study were given a library of engagement procedures. So similar to if y'all are familiar with managing and adapting practice, it has that same frame where there's one sheet of paper on each practice and steps and descriptions on how to implement those steps. And it's all that has been derived from the literature reviews on those practices. And it's a modular design where you can use different practices at different times, and it's interchangeable. And then it's all presented in a coordinated framework. So this is another care process. So similarly to what was used in the India study, it's now within the focus of engagement. So considering the 5 different reach domains, answering if there are concerns in those domains, and then identifying the focus, and then responding with various practices. And so you go from left to right on this one sheet of paper to identify what you will do next in a session, and what practices to use for what problem, and then it helps kind of structure just the decision-making flow. So all of these resources can be seen within this plan, do, study, act cycle. So identifying a problem, selecting a practice, implementing that practice, and evaluating the outcome. So you identify with the assessments, selecting it using that one sheet of paper with the care process, implementing with those engagement guides, and then evaluating using that same care process sheet. And so we used this decision support system across 2 different sites, one in California and another, well, multiple sites within California and multiple sites within South Carolina. So very different kind of settings where in the California, the site used a lot of evidence-based treatments. It's incentivized. And then in South Carolina, it was rural. There was historically a lot of challenges with delivering evidence-based practices. Here's our method. We randomized participants from both sites to either a decision support system group or a comparison group that were just given a list of engagement practices and their definitions, and that was it. So they had the knowledge that these things existed, but no coordinated knowledge system in which to use them within a decision-making process. And then they were trained on each of these respective resources. The practice guidelines, they received training on that. And then the decision support system, it was a 2-day training on how to use it. And then the providers were alerted of youth and families at risk for engagement. And then we audio recorded and transcribed their supervision sessions. And we used multiple measures to understand what was happening in the room during their clinical supervision as well as treatment, but I'm focusing on clinical supervision here. So we had one measure to understand efficiency. It was part of a broader coding system where we looked at the extent to which the participants got right down to an engagement issue, prepared for that issue, and addressed it within an entire supervision session. So that was scored on a scale of 1 to 5. One where there was a lot of other things going on, inefficient use of their time, and then 5 where they were making decisions very swiftly, organized, using a very organized way of doing that decisions, and that, yeah. And then I also looked at the length of time they spent in their sessions and within these discussions, and then how many words were spoken when we looked at the words spoken with this by the supervisor and by the provider within the session. And again, the focus is on supervision, but it was within this context of them having a supervision session and then a treatment session and so on. And then I compared the 2 groups. So using MLM, here's some information on the participants. So across both conditions, there were over 90 direct service providers or therapists, about 30 supervisors, all discussing around a little over 200 study cases. Most of them were female, most non-white, and the highest education, about 63% had an MED, and they're around 40 years old on average. And so I used MLM with cases nested within clinicians or providers nested within their supervisors. So what do you think? Which condition took longer for supervision? Just the entire supervision session? Who spent more time discussing their cases? So I'll take a moment while you guess. The answer to that is it was a tie. And so they both spent the same amount of time as groups on their supervision session, but there's more to the story. So to orient you to this graph, blue is the decision support system condition, and green is where it was the comparison group where they just got that one sheet of definitions of practices. And the bars are clustered by state, so California and South Carolina. And as you can see, the dyads and the supervisory teams or dyads and the practice guide condition in South Carolina were only spending about 5 minutes in supervision. So on the y-axis, it's time in minutes. And 5 minutes might not be enough time to accomplish anything that will impact the treatment session. However, dyads in the decision support system in South Carolina were beginning to look more like those in California. And it seemed like they were taking the time needed to engage in a thoughtful decision-making process about their case. And so they, as a group, spent about the same amount of time, but then the decision support system helped the group that was spending very little time to spend more time. So the next question is which condition was more efficient in supervision? So being able to be very swift and organized in making their plans. And the answer was that the decision-making, the coordinated knowledge system or the decision support system, we have to use different acronyms here, that condition was more efficient. And so here's the data on the efficiency scores, scale of 0 to 5, and the average efficiency in these different groups. And so the blue bar is that decision support system, and the green is the comparison group. And so another piece of data I looked at was I wanted to get a sense of the words spoken as a proxy for participation by both of the folks in the dyad. So how much did the supervisor participate in supervision versus the provider? And when looking at the comparison group, we saw that, or actually when looking at the comparison group, there was a lot more one-sided where the provider spoke the majority of the session. But the decision support system group, it looked like there was a lot more back and forth in their conversations. And when I looked more closely at the transcripts and the practice guidelines or comparison condition, the supervisors tended to be more affirmative in their responses to the provider's thoughts. Like they would give that 30% is mostly things like sounds good or yeah or uh-huh. But when I looked at the transcripts of the decision support system condition, we saw that supervisors were asking more questions, providing more feedback, and having a much richer discussion on the case. And so in conclusion, we found that the decision support system condition was associated with greater efficiency and more equal participation during supervision, but did not take more time as a whole. Other than, boosting up, those 5-minute, on average, discussions in our South Carolina group. So we have a tool, technology, or intervention that has exciting results. It can be easy to skip past a key consideration. do the people who expected to use it even like it? And so that's another thing that we've been looking at. And also, do the people who are using it, do they improve over time as they use it even more? Like what happens when you train them and then let them, go off and use this resource without checking in with them anymore? Like what happens to their quality of their discussions, the time they spend on their discussions, and how efficient they are with practice? And so, so those are some next steps. And so I'm going to conclude my presentation with this thank you slide that shows all the different names of folks who contributed to this work, and in terms of the broader study in reaching families. And then in blue, I highlighted those that really provided considerable effort on reaching families, as well as provided a lot of mentorship and guidance to me. And the PIs of Reaching Families is Doctors Bruce Torpeda and Kim Becker, who are also on my dissertation committee, along with Dr. Bob Bilder and Dr. Craig Enders. So thank you so much for your attention.
Thank you, Kendra. Excellent presentation and wonderful slide set as well. Great visuals. So I actually have a question about the mental health workers in India. And so I was curious, could you tell us more about their, like what type of mental health workers they were, what their training was?
Yeah, so their training, it ranged a lot. Some had training where it was more formalized, and others were much less so. So some had higher degrees like the MED, and then others were more trained in that setting and went through like more like workshops kind of level training. And so when we recruited the participants for that study, we yeah, cast a broad net as part of this like feasibility piece to pilot it.
Great, thank you. And we have a question from Patty. So she also says, great talk. I'm not sure if you can see it too, but yeah, so let's see. Yeah, she's just saying such an important topic for dissemination of care and how to disseminate practices of decision making. And that she likes the stepwise process of choosing what to do based on what's available. And for study one, how do you think cultural factors, for example, differences in how people describe what is a symptom and what is a problem, affected provider responses on the questionnaires and knowing how to respond clinically?
Yeah, we saw this question come up throughout the process of developing the treatment, the PRIDE protocol, where providers and patients use different language to describe symptoms that our team used back in at UCLA. Like tense was a word that came up a lot, that could encompass kind of like how we use irritability, where the patient is tense, which could be anxious, angry. And so in that work, like as part of that protocol is defining, these experiences that, the patients bring to the room, and then being very concrete in the symptoms descriptions. And we collaborated across a team of providers who worked in India and had this expertise of that context and that setting and the language used, along with our team to try to bridge, that those two, perspectives, and be able to kind of apply those knowledge bases in a way that would be attuned to the patients in India. And it was a iterative process of even just designing the protocol. I did a lot of the illustrations. You didn't see any of that, but like being able to show different, like using like client-facing illustrations, like does this look like something that would be appropriate for this context? And there was like a lot of discussion, including like, what skin tone do we use, and how light or dark or medium like do we make in this portrayal of these patients. And so it was a lot of collaborative discussions and across both language and visuals for this. And then in terms of this study, circulating the vignettes to various folks, having them read through it and provide their comments on to make sure that it was appropriate and the way the language was, it would be very clear to a variety of perspectives too.
Yeah, that's a great point with the visuals and getting things right, because it is pretty nuanced when you're, conducting these these protocols and implementing them. And so yeah, you definitely got to think about these things, these little things. And yeah, a couple more questions. So just thinking about study two, have you considered what your future directions would be for that?
Yeah, so I'll share. So part of my dissertation will, I see a thing. Okay. Oh, I'm seeing, sorry, I'm just distracted. I'm reading more on a chat here. Okay. So just want to share. Oh, I also, let's see here. Play from current slide. I'll pass through like the funny pictures that I had here. So one
It's in presentation mode.
Oh,
Just
oh, whoops. What did you say?
it was in presentation mode, that's all.
Oh, okay. Let's see here.
But you could probably just scroll through it on this screen
Oh, okay.
if you
Great.
just
Yeah,
close
that's
the notes
fine.
box.
Yeah. So looking the next step I want to do is look at the question of paced learning. So and learning over time with these resources, which can help kind of us train up providers and supervisors where they get the information they need just in time, so then they can execute it in a way that we can kind of build their competency. And so I was curious about how decision support systems might play a role in paced learning. And so what I'm doing in my dissertation is looking at just the group that participated in the decision support system training and was using it, and seeing their performance over time on metrics of quality, effort, and overall efficiency after they've repeatedly used the system. In terms of a spoiler, I've already started. Oh, actually, I'll say so quality and effort measures, and then looking at specifically, similar to what I did in India, looking at considering a problem and selecting a problem, and considering a practice and selecting a practice. So the extent to which they've discussed these problems and practices, and the extent to which they were able to prioritize something to do. And the spoiler is that when I've been looking at it over time, I've seen that. So I was like, oh, wouldn't it be great if just like on their own, their quality just improves in terms of the quality of their thinking on considering a problem and selecting a practice. And wouldn't it be great too if they just did it quicker? And so like, being more efficient in supervision. And unfortunately, what I found was that the quality goes down after training, after more like repeated use. It's still very high, but that's like the highest was immediately after the training, like in terms of these metrics, what you would want to see. And then also over time, they tend to work even harder, where they're putting forth even more effort into their discussions. And I used the amount of words they spoke when considering a problem or selecting a practice, for instance, as a proxy for effort, as well as time spent. And so I was like, oh man, shoot, but also it makes sense because, they're using it on their own. And in terms of paced learning, like they're at this certain level on these booster consultation sessions, just like we see in other kind of training, competencies greatly benefit and can kind of help kind of sustain that quality, or like kind of help them level up as well. So that'll be like a next step too, of how much consultation will be needed to keep that quality and effort, as desired, and then how can we level them up to the next stage. Yeah, in line of this kind of paced learning kind of effort.
Great. Well, yeah, that sounds like, yeah, excellent next steps. And yeah, just, looking ahead, what areas of research or innovation do you believe hold the most promise for improving clinical decision making in mental health?
So one thing that I think most people are excited about in their respective domains across the board is like AI, and how can we leverage AI to help support clinical decision making. And we're already doing it, to a certain extent, of course, using these decision making algorithms and being hopefully thoughtful about, the limits too of decision making algorithms. But in our work with transcribing these treatment sessions and supervision sessions, we have a lot of data of what's actually said in these rooms. And there, I would love to see a computer be able to perform just as well as a trained coder on being able to assess the quality of discussions in supervision, and then provide, just like you would with a human consultant, or if you're thinking in treatment, you have your supervisor live chatting you during your session. It would be really cool to get in vivo feedback during supervision to help support the quality of the discussions, as well as, to increase the efficiency as well.
Are you trying to put us all out of jobs? Kendra brings in the next wave. But yes, yeah, although it's, AI is so controversial, but it has so many implications just for, just benefits, societal benefits as well. So, um, yeah, and any other questions from our audience? All right. Well, I think with that, we will end a little bit early, but thank you so much, Kendra. She's our first intern to go for the year. Very exciting, great stuff. And yeah, keep on going. Yeah.
Thank you.
Oh, hold on. Let me see. I see something. That's Patty. She's just saying thank you. Great talk. All right. Well, have a good day, everybody. And yeah, see you next time. Bye.